Good day, my dear postgraduate students. Welcome to Recent Advances. The present class is from Recent Advance 25, Chapter 2. And hats off to Riddhi Sood and Amanjit Ba from Postgraduate Institute of Medical Sciences, Chandigarh. They have done an enormous level of work at the international forefront. COVID virus, we all know, having begun in 2019, hence the name COVID-19, causing a respiratory distress, otherwise called as SARS-CoV-2. It originated in Wuhan 2019 and was declared a pandemic by WHO the same year. The morbidity and mortality is very well known. 1.2 million deaths worldwide and more than 5 lakh deaths in India. Still continuing, though at a very low level now, thanks to the efforts of the government. The mode of action is more or less similar to the MERS, Middle East Respiratory Syndrome. But then you find that the degree of severity, morbidity, mortality was much less. But today, it is something that mankind would fear forever. It is an RNA virus transmitted by the respiratory route. But then you find that it is not mere infection. There are multiple other mechanisms which declare the degree of severity. We shall be seeing that subsequently. The problem for the viral survival was immune escape from our immunological mechanism, difficulty in diagnosis, and also the mode of treatment. Hence, it survived, creating havoc for the past 2 years. Also, a great degree of mutations from within the virus as well as the ACE2 receptors paved the way for its severity. We should be remembering the ACE2 receptor mutations and also that new variants have evolved called as alpha, beta, gamma, delta, maybe more nowadays. So I would like you people to have this in one corner of your mind. The clinical variants are divided into acute and long. Acute is an extremely short duration before the onset or even the end of the disease, whereas long is a prolonged mode. Chronic is somewhat indolent. You can live with the disease, you won't die of the disease. The variants vary widely and can affect almost any organ. Respiratory system, it bore the brunt, and the period is 1 to 4 weeks in acute. Less than 4 weeks, we can say. It is progressive despite a negative RT-PCR. Many of the patients were found negative, but then they had deterioration in their systems. Also, the radionucleotide antigen testing on the nasal swabs were negative, but the deterioration was present. This can be called the post-acute COVID sequelae, affecting 30 to 80% of the affected population in the UK. Then there is another variant called subacute. After acute comes subacute, which is lasting for 4 to 12 weeks. And the long-term COVID syndrome beyond 12 weeks. They say that even now there is a post-COVID sequelae which is affecting many a patient. Now, what is a mode of injury or harm by the COVID virus? Even if a layperson asks, you should be able to explain. 1, it can be because of a direct irreversible injury by the virus itself. 2, it can be because of the immunological sequence of events that it has elicited. Third one can be because of dysfunctional coagulation, bleeding somewhere and clotting elsewhere. That has led to multi-organ damage. There can be superadded infection. Any of the viral infections, you find that there can be a neutrophilic infiltrate indicating that there has been a bacterial infection. Also, subsequent to the treatment with steroids, a wonder drug, It can take a life or it can save a life. But then there have been changes because of that. There has been a high degree of infectivity and mortalities, but not much autopsies have been done. Therefore, the study was very, very limited. However, thanks to some dedicated centers where biopsies have been done, we have been able to study the sequence of events in a COVID afflicted patient. So here we see the damage can be direct, it can be immunological, it can be due to coagulation, thrombus formation, superadded infection, bacterial, and the administration of steroids, which can lead to opportunistic infections. The clinical manifestations you people can go through. Radiology was one discipline that has laid down a wonderful source of diagnosis and the study of the sequence. It has done a marvelous job. Pathology, in fact, was on the back front because most of the bodies were buried. Thanks. Because of that, we need not have taken the risk. But even otherwise, there is something that we have discovered which we shall be seeing. Radiologically, these are the important findings. One is a ground glass opacity. Two, a crazy paving pattern. Third one can be interstitial thickening within the lungs. Parenchymal bands can be found in the periphery. And in severe cases, there can be diffuse alveolar damage, DAD. All this have been discussed in my other classes. I would like you people to kindly revisit that. There is something called a CTS, CT scan severity, and the scoring is from 0 to 20. Clinically, there is an acute respiratory distress syndrome. It is not adult respiratory distress syndrome. So do not make a mistake. Now, this is the appearance that we people are seeing. It is called a ground glass opacity. What is a ground glass? We shall be see. Now, these are all opaque areas. I am not able to see something beyond this. It is not transparent completely. And also I find that there is a confluence or a merger of this ground glass areas within the lung. This is the three-dimensional picture thanks to Radiological Society of North America, wherein I am able to see the ground glass opacity. See, this is one. A glass beaker, a lid for it. I find that this particular area, I am able to see the blue background, which means it is transparent. Whereas from this, I am not able to see the same because it is ground glass. Even in your slides, there are slides which are called as ground glass slides. Now, this is a wonderful picture, a CT scan, in which, if you see this one, there is a meshwork which is leading to a kind of a honeycombed appearance that is present. It is usually present towards the periphery of the lung in the subpleural region. And for this, there is a wonderful reference over here. It is a case of a study in patients with lung cancer. So, what is the malignancy? Probably this opacity is one, but then there are the other changes which we are seeing in the periphery. There are areas of fibrosis that can be seen. There can be a honeycombed appearance. They can be interlacing or they can be overlapping on each other. Now, these are the pathological changes. These were not seen initially, but now with the study of the specimen that have been retrieved or stored, we have found a lot of changes in the COVID patients. In this one, these are the things. There is an exudate. Always, in any case of a pneumonia, take a lobar pneumonia, for example, there will be a stage of congestion, red hepatization, gray hepatization, resolution. If it persists, there will be organization. You can apply the same thing over here. Initially, there is a stage of an exudate. So I find that there will be some amount of inflammatory infiltrate that is there. Also, there can be a proteinaceous material present along with it. In this one, I am finding globules of protein within the alveolar spaces. Also, please note that there is a merger of the alveolar sacs leading to irregular outline. It is not an emphysema, but we are seeing this one. Third one can be a fibrin meshwork that is found within the alveolar spaces. It is not uncommon. You people will already have seen this one. So you find fibrin in which there can be some inflammatory cells. This is important. There can be desquamation of the epithelium. Both the type 1 and the type 2 pneumocytes can be shed. But then there is a replacement more of the type 2 pneumocytes. Again, there can be a squamous metaplasia which may be present. And if we are lucky enough, we may be able to find some kind of an inclusion. This is a viral inclusion that has been found in this particular case. The reference again goes back to the earlier note. So these are the things. Apart from the pneumonia part of it, an exudation and then an interstitial edema, there can be a hyaline membrane. In fact, even I was of the opinion that it is a hyaline membrane that is preventing the permeation of the oxygen. That was leading to the respiratory distress. But it is not as simple as that. There are the other changes which we will be seeing. Squamation and the metaplasia. The type 2 pneumocytes will be proliferating with prominent nuclei, eosinophilic nucleoli. Viral intrusions may be seen. And vascular thrombi, this is the nightmare. And whenever it is prolonged, there can be organization and fibrosis, as a result of which the lung becomes more or less crippled. Inflammatory infiltrate in many viral infections. Please do remember lymphocytes and plasma cells. Look at this one. I find that multiple areas of ground glass opacity are there. They are here, but then they are merging with each other to form larger irregular areas. This is the case of a bronchopneumonia that is there. But then there is an interstitial fibrosis as well. But when these are more uniform, it can almost mimic a lobar pneumonia. But in this case, it is restricted to a bronchopneumonia. Now, what will happen because of this pulmonary sequelae? There is a diminished pulmonary function. Very obvious. Restrictive ventilation. That is why ventilators were brought in. We will find the pros and cons of it. In SARS 2003 also it was present, but only about 20%. Here, 60 to 80% of the cases have been affected. There has been an interstitial thickening, irregular external surface of the lung, and a honeycomb remodeling along with the fibrosis. Vascular, there can be wrinkling, there can be reduplication of the elastic lamina. There can be, of course, thrombi formation. And what are the indicators that we people should look for? They will be the transformation growth factor, which leads to the accumulation of the fibroblast, high angiotensin II, low ACE2 expression. This is the major culprit. There can be pulmonary fibrosis, villi, not villi. This is ventilator-induced lung injury, oxygen toxicity, and we were giving oxygen therapy. My professor of medicine used to say that carbon dioxide is a respiratory stimulant, oxygen is a respiratory depressant. Pneumonic consolidation, whether it is broncho or lobar, predominantly broncho was seen, and COVID stress scales were increased. So these are the indicators of the clinical progress of the patient. Gastrointestinal tract is another one. It is secondary, not directly affected, but then you may be finding areas of ischemia, areas of hemorrhage and necrosis. Sometimes gangrene and perforation can be present. Microscopically, there can be apoptotic changes and reactive changes. Superadded infection with cytomegalovirus also have been noted in patients. And it is positive for the nucleocapsid protein of COVID-2. The damage again is because of the ACE2 receptors. In today's class, if you remember this, I'll be very happy. This is a wonderful schematic picture which I've already presented. I would like you people to kindly go through it. And thanks to this wonderful source of reference from nature. See what is happening over here. So in this one, there is the virus that is getting attached. So these are the proteins on the surface of it, and this is a receptor binder over here. Once it is bound, there is an invagination of the epithelial membrane, as a result of which there can be a phagocytic activity that is brought into action. Now, this can lead to a direct cytotoxic effect, and this particular system is brought into action, RAS, renin-angiotensin-aldosterone system. So you find lots of changes can be brought in. Angiotensin 1 getting converted to 1 to 9. It can also activate the angiotensin 2. Again, 1 to 7 is being activated, and there is a down regulation of the ACE2. It goes out of control, and then the various processes continue. There is also the endothelial damage. This is a blood vessel endothelial damage. Apoptosis can be occurring. Decreased amount of fibrinolysis. So there is the precipitation of fibrin thrombin formation. Thrombus formation can be there. Also, there can be the formation of the cytokine storm. That is there because of lymphopenia is what we people see in the peripheral blood. So kindly do remember this and please go through it. Summarizes almost the entire happenings. In the cardiovascular system, this is not very commonly affected, but if it is affected, one of the most common changes will not be an infarction or anything. It will be an arrhythmia because of the damage to the conduction system. This has been seen earlier in the other viruses also. So there can be a mild pericardial effusion, there can be an edema, lymphocytic infiltrate again. More important will be, look at this particular picture, the ventricles have all become swollen, blown up or flabby. This kind of a change is also seen in diphtheria because of the carnitine cofactor. But in that case, you'll be finding more of a fatty. Here you find it is flabby, and then there can be an arrhythmia that is setting in. And the mechanism is because of the ACE2 receptors. Thromboembolism is very common thanks to Heart Journal of Clinical Pathology. This is a super picture which we should appreciate, whether we remember or not. You find this is a myocardium, and within which I am able to see the blood vessels. These are the endothelial cells, the yellow marks over here. And there is the stasis of the neutrophils. Maybe some kind of a diabetes and an emigration is trying to be settled. There is also damage to the myocardial fibers which can be seen. And here again, there can be some amount of damage that is caused to the interstitium. In the electron microscopy, there can be the inclusion. These blue arrows indicate the inclusions of the viral particles. So these I would like you people to kindly bear in mind. Hats off to them for these wonderful pictures. The CNS is another organ that has been affected. There can be a loss of smell, loss of taste. Kindly go to the manifestations. I have explained it vividly. Thanks to those authors. Fetal autopsies as well as infected mothers have been found to be positive for COVID-2. The patient will develop a meningoencephalitis. Always in viral infections, there will be an encephalitis. In bacterial, there will be a meningitis. In this case, there has been meningoencephalitis. There has been a cognitive decline. It is a clinical manifestation. The patient is in a state of confusion or fog. And there can be an ischemia. Thromboembolism can be seen, which will be leading to either macro or micro infarcts. This is a case of a hemorrhagic infarct that I'm seeing in this. Hypoxic changes are there. And ADEM, acute disseminated encephalomyelitis. What is the immunological staining that we people can do? The markers, neuronal loss, GFAP for gliosis, CD68 for microglial macrophage proliferation. And thanks to Neuropathological Italian experience, this is the reference. Renal pathology. In the kidney, there are different components. I will not go into it, but please do remember it is the tubules that will be affected more commonly. There is a tubular injury, there can be a dilatation, flattening of the epithelium, loss of the brush ball. Sometimes there can be fibrosis in the interstitium and microthrombi within the blood vessels. If you are lucky enough, immunofluorescence will be able to demonstrate the virus. And also, you should note that if the patient is having a pre-existing diabetes or hypertension, this will worsen the conditions. Again, ACE2 receptors are upregulated. And thanks to Curious, look at this particular picture. I find that there is some amount of inflammation in the interstitium. It is mostly the tubules which are being affected. The glomerulus is relatively normal. There can be a perivascular fibrosis that is seen. And also the smaller blood vessels can be showing microthrombi. These are the renal changes which people can remember. And if the patient is a diabetic, there can be the other diabetic changes as well. The hepatobiliary system has been extensively dealt with. I would like you to go back to it because that is also a topic for us. All said and done, there is a widespread steatosis, there can be an inflammation, and also a local necrosis. Lobular necroinflammation is the term that has been given. Apoptosis, look at this eosinophilic bodies over here, not much of inflammation around. Apoptosis and portal pruritus with lymphocytes are common. And thanks to nature, changes in the liver at autopsy. In the lymphoreticular system, you find that there will be a reduction in the peripheral red blood cells. There is a pancytopenia, particularly a lymphopenia and a neutropenia. And in the tissues, you'll be finding the depletion of the lymphoid follicles, what we call as a burnt out syndrome. That is what is happening in the case of HIV also. You find initially there will be a hyperplasia, but later on the follicles become burnt out. Common in any of the viral infection. And spleen, being a lymphoid organ, will be showing a decrease in the white pulp. There is increased amount of phagocytosis, which of course might not be that very effective. This is an important one. You find that there is an infection with the COVID virus over here. There is an attachment, there can be an invagination, and it is getting activated by means of the various organelles, and it can go and it can damage the various tissues. In the lung, for example, there can be the fibrosis as well as hemorrhage and necrosis. There can be the R.A.T.S, and there can also be multi-organ failure. In the blood vessels, there can be endothelial dysfunction, micro and macro thrombi. But that is not all. You find that there will be the activation of the various mediators such as interleukin, interferon, tumor necrosis factor, macrophage chemotactic factor, again another interleukin, etc. So all these get activated. You can imagine the amount of damage that can be caused by that. This has been again dealt with in great detail in one of my classes. So much so that this has been described as a storm in a cup of tea. So here what am I saying is this. It is a thematic and a beautiful picture that is it has been drawn. So there is a boat or a yacht over here. There is a cup of tea acting like an ocean of water. And there is a rain adding to the wood. So this is called a storm in a cup of tea. A beautiful theme. Generally, this is supposed to be an argument evolving over a cup of tea between individuals. This is again from nature, a wonderful series of pictures. There is a lymphopenia. SARS virus is here, it affects the T cells. There is the activation of the various mediators such as the interleukin 10, etc. They will be affecting the T helper cells. Initially, it is the helper cell 1 and 2, but later on it is TH70. They will be releasing the various mediators. One cell, always the lymphocyte will be affected first, after which there will be an activation of the macrophage. That is what is happening over here. You find that there is an activation of the granulocyte, monocyte, colony stimulating factor, recruitment of the monocytes. The same thing is happening over here. There is a cytotoxic T cell, then it gets damaged and reduced. NK cells are also reduced. There is again a proliferation of the viruses. They affect the other cells. Again, it leads to the macrophages. There is the various mediators which are being released by it. And hence, you can have the cytokine storm as mentioned earlier, or there can be the activation of the other immune cells. Always these viruses have got this effect. They enter a cell, damage the cell, release the mediators, kill that cell, then go on to infect another cell. That is why the patient is developing a lymphopenia or a burnt out cell. The mechanism of the extrapulmonary condition, this is supposed to be extrapulmonary, but it can be for a basic mechanism of the disease itself. Now, what are the modes of detection? Always you people should memorize some methods. Whether it is application or the methods of diagnosis, always have a list memorized by you. Formalin fixed tissue, you can do a immunohistochemistry, or there can be an in situ hybridization. The antibodies will be for enolum or for ORF6. And there is a lysis of the lipid-laden macrophages in the lung. And there is a deposition of the viral protein in the hyaline membrane. These could be made use of in the lung biopsies for demonstration of the viral antigen and the antibodies. electron microscopy by means of a throat swab, which has been a failure. And in that one, in a glutaraldehyde fixation, the ultrastructural virus can be demonstrated. It is about 70 to 80 microns, nanomicrons in size. A zero is missing over here. And the viral capsids will be 50 to 75 nanomicrons. These could be demonstrated by means of electron microscopy. And from formalin fixed paraffin embedded tissues, you will be able to retrieve the RT-PCR, which can be positive. So look at the series of positive tests that can be positive in a case of COVID-19. The basic strategies can be molecular, where a genome can be demonstrated, or it can be the antibodies against the SARS-CoV-2, or it can be the structural demonstration of the virus itself. So have this theme in mind. I think you will be able to recollect most of the conditions. There can be superadded infections. Any of the viral infections, that can be bacterial infections. But what played havoc was, it was mucormycosis, aspergillosis. And there can be the mycoplasma pneumonia that is there. The rhinoorbital region is the commonest region that has been affected by it. So we all know about it. I did not claim the pictures of it. You people have already seen it in your institutes. There can be the loss of vision, there can be ptosis. The infection can be disseminated to other regions. And it can be complicated by the administration of steroids. This is where it came into play. The steroids, it saved lives, it took lives. And diabetes is another predisposing condition. Candida, etc. By itself, you people should remember, opportunistic infections is a question for us. Viral inclusions, intracytoplasmic, intranuclear inclusions. I shall come to them at a later date. So these are the key points of the summary. There can be a direct cytopathic effect by the virus. There can be a cytokine storm. There can be a suppression of the immune system, abnormalities in coagulation, and complications by steroid therapy. Respiratory, there will be fibrosis. There can be a remodeling. Honeycomb lung can be there. Fungal infections are very common. So also in the sinonasal region. So ultimately, the COVID-19, it has dealt with a lot of these topics in the recent advance 25. I would like you people to kindly go through them. Otherwise, I would presume that we have come to the end of COVID-19, at least as far as recent advances 25 is concerned. They have done an enormous and a wonderful job. They should be congratulated for that. And thank you for your patience.